But the current definition of long COVID is just that people who have symptoms more than 4 weeks. But this particular study defined long COVID using a point system and has many learnings in it, and which we can talk about, but has that much more relevance to the residents of Arizona because we have more of this condition than the average person.
Any idea why that might be?
Yes. So you may recall that during the height of the third surge of the pandemic and then the fourth surge as well, especially the third, Arizona had the unfortunate distinction of having the highest amount of COVID cases and COVID-related hospitalization per, density of population in the country, and also at one point in time was the highest in the world. And so when you have such severe COVID, it translates into greater risk for long COVID. Because one of the reasons for long COVID, of many, is that the more severe damage that you suffer from acute COVID infection, in other words, if someone was hospitalized as opposed to someone having COVID and recovering at home. And even in the hospitalized setting, if someone was in the ICU because their lung and body organ damage was worse than for others, they're more likely to have long COVID than someone who was just hospitalized and not in the ICU, or someone who was never hospitalized. And that's because, just like a wound that we may suffer, the larger the gash, when we accidentally cut ourselves, the longer it's going to take time to heal and the more help it needs to heal. And similarly, the more severe the COVID infection, the more likely that we have long COVID. And since Arizona, especially Maricopa County, when you look at it from a county system standpoint, Maricopa was again the lead county at one point in time across the US. Arizona was the lead state across the US. So de facto, by virtue of suffering a larger burden of the acute COVID, we are also, along with some other states that are along with us, in the top bracket of states that is suffering from long COVID related burden.
It's tough because by this point, so many of us have had it at some point. Psychosomatically, we feel like, oh, I'm coughing today, or I'm fatigued today. But what is the protocol, and how does this study help us patients, us lay people, understand how to handle these symptoms and how to make that distinction when to talk to a doctor?
Yeah. So one of the key aspects, if I'm understanding your question right, is that this study, how does it help us? Well, it helps us with regards to coming up with the first way of defining the long COVID condition. So far it's been like anybody who has long COVID for more than 4 weeks. New symptoms or symptoms that are worse than what they were before acute COVID happened is considered to have long COVID. Now, what this particular paper is showing is that you can almost take a pencil and paper, put these symptoms on a sheet of paper, and the patient can check they have it or they don't have it. And based on that, the score points that each symptom gets tallies up. If it's more than 12 or equal to 12, they have slam dunk COVID. If it is less than 12, and they believe they have a new symptom that's either completely brand new or is worse now than before, they could still have long COVID, but it's not slam dunk. We need to do more research in figuring them out. So we don't want people to be disappointed if they look at this press release or if they look at the findings of the study and they say, oh, my symptom is not represented in the top 12, and they feel dejected. Well, they need to know there are a total of 34 symptoms that's in the paper, in the publication, that were more prevalent in people with long COVID than people without. how we define as long COVID. Now, just so happens that these 12 are the lead runners in that 34. That means there are other symptoms there in that list that are also part of long COVID. So by knowing exactly who are the ones with long COVID, we are now able to do blood tests. Remember, these 10,000 people or so also gave blood. The vast majority of them gave blood samples, and they are undergoing tests. They're still in a study. So we can take those blood tests and figure out, with their permission, of course, which they gave permission for us to use, to look for biomarkers, to find for blood tests that will define who has long COVID and who doesn't. Now, that's going to help in two ways. One, that blood test can now be used in people who didn't reach that score of 12, find out who are the people with long COVID there that we missed by coming up with a score of 12, so that we can redefine those people as having long COVID, and so that they don't feel dejected and disappointed that they didn't have COVID because of this weird score that they need to pass in order for them to get diagnosed. But if that blood test is positive in them, for example, then we know that they too have that long COVID. That blood test that we discovered by using the people with slam dunk COVID as the gold standard, because it's indisputable that the people with a score of 12 or greater have long COVID. We use those people to try and help the people who didn't measure up to that score. So that's one key learning and point here, is that people shouldn't feel dejected and disenfranchised if their symptom is not on that list. The second reason why the symptom may not be on the list is, even though there were about 30 odd symptoms that were significantly different in people with long COVID than people without, they're not on that short list. That's because those were related very closely to each other, and we cannot put all those symptoms in that final score, because it will falsely inflate the scores that they get, because they're closely tied to each other. So it's a situation that mathematically we describe as collinearity. And so in that situation, what they need to know is they need to look at that other list, which are closely tied to these top 12. And so if their symptom is listed in any one of these 34 or 44 symptoms total that were involved in this condition, that means they do have long COVID. They need to just talk to their doctor. And now these blood tests that we'll use in the slam dunk COVID patients will also give us insight as to why people develop long COVID at all. And that'll give us insight as to what treatments may actually work for them. So there's great opportunities. Now, this is just the beginning step. You may have heard, the way to look at it is, you may have heard with high blood pressure and diabetes. The high blood pressure definition was changed about 4 or 5 years ago. You may recall, they lowered. Similarly, for diabetes, almost every 5 to 10 years, they keep lowering the threshold for diagnosing diabetes. So the original definition of diabetes was, going back 20 years ago, when I was in medical school. It's very different than the definition of diabetes today. Why? That's because as we learn more and more about the condition, we start out with what we call a working definition, and then we refine and further refine the definition over the many years that follow. And that's exactly what's going to happen with long COVID. This is the early definition of long COVID. These patients are already undergoing tests. They're undergoing x-rays, breathing tests, sleep studies, and all of those clinical tests. That's going to further change the way we define long COVID. So you may see another paper, literally 6 months, 9 months from now, that may redefine it further. And there's work ongoing with regards to that. There's also blood that is being collected, and that blood work will be done, and that will further give us clarity as to why someone develops versus doesn't develop. And that will further define it, just like how with the diabetes and blood pressure definitional changes, these things will keep changing constantly.
Sure. Will the blood test be available soon for folks to get at the doctor's office?
We are, it really depends upon what those blood tests are. Now, if it is, I don't believe it's going to be a straightforward blood test of a known protein or chemical that we normally check. it's going to be something, an unusual protein that's normally not tested in the clinic setting, but only tested in the research setting. So hundreds of thousands of proteins, chemicals, RNA, DNA, autoantibodies are all being tested. So some of those may be commercially available, but I would say a vast majority of them are not. And so we'll have to wait for commercialization for them to become available. But the key thing is that's why there are going to be centers of excellence. We are a center of excellence by virtue of the fact that we are in the Southwest United States. The University of Arizona is leading pretty much the charge. It's not Southern, there are no adult cohort centers in Southern California or anywhere in the state of Arizona. It's us. And so we are wanting to, we already are de facto in that way a center of excellence, but we're also going to be creating a clinical center of excellence so that we can share our learnings not only by helping patients, but also educating other doctors about how to diagnose and treat, which those efforts are already ongoing with research support that we have from the CDC, from NIH through a different mechanism called Community Engagement Alliance Against COVID Disparities, and also awards from the Department of Health and Human Services, which is outside of NIH and HLBI. And so it is incumbent upon us. We can't take care of everybody. What we need to do is we need to educate the providers so that they become savvy and they become experts. And a lot of this is tied to new treatments that need to become available. And we are actually going to be part of clinical trials that are starting literally in July, where we're going to be treating long COVID patients with new novel therapeutic agents. And so all of those have been work that's been ongoing for the past year. From May of last year to May of this year is when we put in an application in May of 2022. And those were selected. And we are part of the people who are writing some of those clinical research protocols. And the trials are imminently going to be starting between July and November, where 5 trials are going to start for people with various what we call symptom clusters. Or what do I mean by symptom clusters is that out of all of these various symptoms, over 30 odd symptoms, these symptoms don't uniformly occur in people. They seem to have friends amongst themselves. They congregate. They're occurring in little clusters. So people with fatigue are more likely to have post-exertional malaise, more likely to have brain fog, more likely to have sleep disturbances. So those 4 symptomatologies or symptoms are more likely in a given.
You're frozen. I'm not sure if you can hear me, doctor.
But that's how we did it. We had our, we read that.
I'm so sorry. My laptop lost power. So I guess
I have been there. No worries.
Sorry
Thank
about
you so much for calling back in. I appreciate
Sure.
that. And I know you have to go pretty quickly here, so just a couple more quick things. Where are we, just for my own edification, where are we right now with treatment?
So with treatment, we're already treating people with various treatments that we know are promising. Um, we have some clarity with regards to how cardiopulmonary rehab, actually, there's some early data from the UK showing that it's beneficial. So doing cardiopulmonary rehab without aggravating post-exertional malaise and doing it under supervision is beneficial. There's data to support that. The second thing that we know is giving blood thinners did not show a difference in reducing problems related to recurrence of blood clots, which one can argue is a long COVID related problem. And so we need to, what it says that we need to be more selective on who we give blood thinners to. Other than those two trials, the other trials are very small and nothing big. And so the big leviathans here are these 5, what we call adaptive platform trials, going after those symptom clusters that I told you about, that are going to be tackling each one of those particular symptom clusters in a particular way. And so that is still work in progress. And I can't share more than that at this point in time. It's just that they are imminently coming.
Oh, quickly, I lost you in the middle of the symptom clusters discussion. Can you explain for folks how that works, what that means?
Yeah, so as I was mentioning, there's about 30 odd symptoms that are more common in people who have been infected and are suffering from long COVID related problems. And those symptoms, there are 3 or 4 or 5 of them that sit together, and they're friends with each other. And so someone with fatigue has more likelihood for having chronic fatigue syndrome, post-exertional malaise, brain fog, and sleep disturbances, for example. And what that tells us is that, and then someone with shortness of breath, cough, respiratory symptoms, palpitation, cardiac symptoms, they may, and dizzy palpitations, where they suddenly stand up and they feel tachycardic, they may co-locate with each other. What does that does is 2 things in regards to the importance of that. One, it gives us a glimpse as to how and why the disease may be happening. It gives us clues that this is affecting the neurological system. And this person is affecting the lungs and the heart more. And this person is affecting the GI tract more. It gives us some amount of clues as to why people would be getting long COVID, first off. Secondly, if they collocate with each other, it gives us a sense as to, well, those are the people that we need to identify in order to put them in this particular trial. That's why there's not one trial. There's going to be 5 trials, because there seems to be 5 groupings of these people. And so what may work for someone in one group may not work for someone in another group, right? Because we think that the treatment speaks to the disease process as to why they developed it in the first place. And so it has relevance not only for us to be able to diagnose them, manage them, but also it has relevance for giving us deep insight as to why they developed, and therefore figure out what treatments would be most beneficial for them.
And it matters when you had COVID too, right?
It does. There is, we saw a pattern that about 20 to 30% of them over a period of follow-up are getting better. But then we're also noticing there is a trend where some people are developing this condition even though they didn't have it soon after COVID. It's developing weeks later. See, that itself gives us insight that the underlying disease process that's causing it is different in group 1 versus the group 2 that I just described. And so there are 4 theories as to why people develop COVID, long COVID rather. One is there's severe organ damage, as I mentioned before, that put them in the hospital, or put them in the ICU, even within the hospital, versus just getting a mild infection and being treated at home, or having the infection and not even knowing that they have the infection. And so there's various degrees of insult to the body that we see. And so the more the insult, the more likely they have long COVID. So that's one reason. Second reason is there is what we call immune dysregulation, where the immune system is affected by the COVID infection in two ways. One, there is reduced immunity, where the immune system is not able to combat the infection or other infections, and these are the people who repeatedly keep getting COVID. But the other issue is in these very same people, the virus doesn't seem to clear. It's called the virus persistence theory, where the virus is harbored in the body. Now, the question is, should these people be treated by antivirals again? Should they be treated by antibodies? Those are all questions that are being raised. Now, the third group is people with autoimmunity, where the body's immune system starts attacking our own body, much like lupus or rheumatoid arthritis. The virus seems to come and tinker with the immune system in a manner that we know that there are studies out there showing that we're developing autoantibodies, that is autoimmune disease, that is antibodies targeting our own body. That's because the virus has done some mischief as to how the body recognizes us versus something foreign. The fourth theory is something called gut dysbiosis, where the gut bacteria is being affected by the infection. So essentially what's happening is normally we carry about a kilogram worth of bacteria in our body, that in our gut, in our nose, mouth, on our skin, a kilogram of bacteria that we carry that is important for our health and well-being. And especially the bacteria in the gut, it's altered by COVID. And it again affects the immune system, it affects the body's functioning, it affects the gut functioning, and it causes inflammation. So it's a condition called gut dysbiosis. So these are all the various theories for developing long COVID. And so we think that these are manifesting differently in different people, that's creating these congregation of symptoms, or what we call symptom clusters, that manifest disease in different ways. And that gives us insight, not only by the fact that, hey, these symptoms seem to sit together. Well, these are all neurological symptoms. Of course they sit together because the brain and the nerves were affected. But there are certain other symptoms that are sitting together that seem to be in strange company. But that will give us clues as to what is the origins of disease in those people. And in the spirit of precision medicine, where it's not a cookie cutter approach, one treatment doesn't treat all, we have to come up with an understanding of the fact that the treatment for person A is going to be different than the treatment for person B. That's where we need to go. But before we go there, we need to find out, why we think this is happening based on these symptom clusters, which is there in this particular paper. And that gives us insight as to what are the treatments. And once we decide the treatments, it will tell us who are the people that we need to be studying. And that's why there's not going to be one trial, there's going to be many trials. And in each trial, we call them adaptive trials. And in each trial, there'll be 2 or 3 treatments that'll be compared against a sham or placebo treatment, not just one.
It's fascinating to watch this road to inform how we treat this illness. Thank you so much for your time, doctor. It's so informative, and I think our viewers will really appreciate your insight.
Thanks for having me. But there's one other thing I just wanted to mention is that some people wonder, well, we got a COVID vaccine in 9 months flat, in the height of the pandemic, and why is long COVID taking longer? It's an unprecedented effort where researchers who never worked with each other, working with each other across various specialties, and they worry about the cost as well. But I did want to say is that it's estimated that long COVID is costing a $2 to $3 trillion expense in just 1 year. And this effort, both for the treatment trials and the recovery trial, are all part of a $1.1 billion investment. Now, $1.1 billion is just a fraction of a recurring cost of $2 to $3 trillion. And it's definitely a return on investment if we can change the health trajectory of the nation. So I just wanted to put it out there that this is important research, and it will, because of the complexity of the disease as opposed to the complexity of acute COVID, it will take longer, but we're off to the races now with this early definition.
It's so important when you consider the work productivity, school potentially productivity for people. It's very important work.